really diverse in nature. It included demographics, it included diagnosis, medications, procedures, measurements, for example, like blood pressure and BMI. So the data we had was like of a large sum of people. It was diverse and it had like a lot of aspects to it as well. I will now like explain a few terms that we are frequently going to use up ahead. So primary cohort. Primary cohort means that the cohort we're majorly focusing on. So in our case, it was people who suffered from COVID-19. They had a confirmed diagnosis of COVID-19. After that, we had two control cohorts, and we're calling them matched cohorts because we have matched them with our primary cohort in all variables except for the variable that we were testing, and that was COVID-19. So the two cohorts that we selected were people who had influenza, number one, that was our number one cohort. And the other cohort that we selected was people who had respiratory tract infections other than influenza or COVID-19. After that, index event. So index event is like the receiving of a diagnosis. So it could be in our primary cohort, the index event would be when they received a diagnosis of COVID-19. In our matched cohorts for influenza, it would be people who received the diagnosis of COVID-19. That's their index event. And for, influenza. And for people who, for a third cohort, it would be people who received the diagnosis of respiratory tract infections. That was their index event. After that, we select, there was like an eligibility criteria that was selected for this study. So it was that all the people that are part of this study must be older than 10 years of age. That was one criteria. Then they had to have received their diagnosis after or on January 2020, not before that, just after that. And then they must be still alive at the time of diagnosis. Of course, like it's a retrospective study, so if we're studying them, they have to be like alive, right? It's like kind of funny. Okay. After that, they established like a bunch of suspected and established risk factors for COVID-19 and factors that affected the severity of COVID-19. So like it was a long list of these factors that you can see on the screen right now. I'm sorry. Okay. On screen right now. For example, like was like major things like age, race, sex, ethnicity, obesity, hypertension, like a bunch of these things that you can see on the screen. After that, they matched the patients for 55 variables. So like there was like no chance of error because they were really serious with the matching stuff. So like I mentioned previously, the primary analysis was comparing people who had COVID-19 with people who had influenza or respiratory tract infections. Then they also like to make this research more valid, they also like did a secondary analysis. So in that analysis, what they did was compare people who had COVID-19 and then like compare them amongst themselves, like compare the primary cohort amongst themselves based on severity. So for this purpose, they divided the cohort in 4 separate groups. The first group was people who had COVID-19, but their ailment was so mild that they did not require hospitalization in that, like the period that followed their diagnosis. Second was the people who got COVID-19, their ailment was like a little more severe. So they were admitted to the hospital and like they selected a time window for their admission. And that was like 4 days before their COVID diagnosis or 2 weeks after they received diagnosis. Then third was people who had like a more severe form of illness. So those people had to be admitted to ITU, which is like intensive therapy unit. And the fourth group that we selected was people who had an infection so severe that they had altered mental status. They were delirious. And like for these people, we used the term encephalopathy. After that, to make our research more valid and to prove that COVID-19, the effects that COVID-19 causes on mental health are not just like that would be caused by any severe illness. We compared COVID-19 with 4 other systemic index events, and that being skin infection, urolithiasis, fracture of a large bone, or pulmonary embolism. So after that, the data was collected, extensive calculations were done, and result was calculated. For our primary diagnosis, we found out, I'll just like recall the analysis again. For primary analysis, we compared people who had COVID with people who had influenza and respiratory tract infections. So it was found that people who had COVID were far more likely to develop and receive a diagnosis of any mental health, neurological or psychiatric condition. This was calculated in terms of hazard rate. So the hazard rate for people who had COVID was 1.44, which to simplify it means that people who had COVID were 1.44 times more likely to have a right? And then we compared people who had
Where we
COVID-19
lost you
with
for about
people
5 to
who
10
had
seconds.
respiratory tract infections. And the results were pretty much the same.
Navaira, we
Shall I
lost.
repeat the result? Will you slide again? Hello?
Yes, exactly, because we lost you for a while there.
Am I audible right now?
You are
Is it
audible. Yeah, please repeat the last slide again.
okay?
Thank you.
So as I present the results, I would like repeat the analysis again because I don't want it to become cumbersome. So the primary analysis was people who had COVID-19 versus people who had influenza or people who had other respiratory tract infections. So when people who had COVID were compared with people who had influenza, it was found out that people who had COVID were more likely to develop any neurological or psychiatric condition. And this was calculated in terms of hazard rate. So to simplify it, it means that people who had COVID-19 were 1.44 times more likely to develop a mental illness. And then similarly, when people who had COVID were compared with respiratory tract infection patients, it was found out that they were 1.16 times more likely to develop any mental health condition, including neurological or psychiatric diseases. I also added this table. It's not possible for me to uh, read all of these values, but if you could focus on it, it shows like when people with COVID were compared with influenza, the hazard rates were greater than 1 in almost all of these categories. So it means that COVID-19 was likely to cause all of these conditions more than influenza. Then again, people who had COVID versus RTI, uh, um, again, if you could compare and read like a few of these values here, the hazard rates were greater than 1, which means that COVID was more likely to cause any of these 14 disorders mentioned right here, which proved our initial hypothesis. I added these graphs as well. So on x-axis, it shows the outcome probability of any particular disease. And on y-axis, we have the number of people at risk. The red line here would indicate people who had COVID-19 and the blue line would indicate respiratory tract infections, okay? So if you see all of these graphs, the red line is far more steeper and it's like above and the area under the graph is more than the blue line, which basically just means that people who had COVID are more likely to get this particular disease. It was similar for intracranial hemorrhage, ischemic stroke, or any like nerve root disorder. Similarly, for all of these diseases, you can see that the red line is above the blue line, which means that people who have COVID are more at risk and are more susceptible to these illnesses. Okay, for our, then we compared people who did not require hospitalization but had COVID versus people who had influenza or RTI but did not require hospitalization. So this was the cohort that did not require hospitalization. And the data for this cohort again showed that, okay, I'm sorry. Okay, so then again, you can see the hazard rates again. They're all greater than 1, which means that people who had COVID are like more likely to get any of these illnesses if they're not hospitalized. After that, in our secondary analysis, the group of patients who required hospitalization, and we found out that hazard rates were greater for all outcomes that required hospitalization versus those who did not require hospitalization. Third, our third cohort was like I previously mentioned, and I hope you can recall, the people who had an intensive therapy unit admission. So when people who were in ITU and had COVID were compared with people who had COVID, but were not admitted to ITU, it was found out that those people who were in ITU were far more likely to develop neurological and psychiatric outcomes. Lastly, the group with encephalopathy, when people who had COVID-19 and altered mental state had encephalopathy, were compared with people who did not develop encephalopathy after COVID-19. And when they were compared, it was again found out that people who had encephalopathy were, of course, far more susceptible to mental illnesses. There's another table, and I understand that it's getting redundant at this point. I hope that everyone would like just pay a little attention to the values that are again mentioned here. The hazard rates are far more greater in people who required hospitalization versus people who did not. So in our previous graphs, the values altered from like 1 to 1.9, like at max. But here, like it has elevated to 3.09, which means the people who required hospitalization were like 3 times more likely to develop mental illnesses compared to people who did not require hospitalization. Then again, in this column, we compared people who were in ITU versus people who were not in ITU. And again, the hazard rate was 5.06. And it was like great, like pretty high for all of the illnesses mentioned below as well. Lastly, when people who had encephalopathy were compared with people who did not have encephalopathy, we were able to find out that again, all of the hazard rates in this column are higher than 1, which means that people are more susceptible to have mental illness when they have COVID-19 as well as encephalopathy.
Navaira, I'm so sorry to interrupt, but I think we're
Again,
having some
Kaplan-Meier graph, monotonous, but still it's really interesting if you see it. So the red line here indicates people
Navaira,
who had COVID-19 and did have encephalopathy, and dotted red line indicates people who had.
Hello, Navaira.
Okay, we're having internet issues again.
Yes, we are. I think you need to, your sound gets distorted.
Yes, I can hear you. Can you hear me?
Yes, I can hear you now. Your sound gets distorted every now and then. I think we're having some issues.
Hello?
At your side.
I think it's the like the bad weather tonight. I think that's what's causing this.
I think it's that, but it's all right. We understand the internet issues.
Do you want me to like repeat the previous slide as well?
No, I just want you to continue from where you left. I'm so sorry to interrupt. Just continue from where you left.
Do you want me to repeat the line? No, I'm really sorry. The internet is really bad tonight. It's just the bad weather. It was really windy where I live. I'm sorry.
Yeah, I get it. It's very windy.
I hope everyone was still able to understand what I said.
No, we were, but your sound was getting distorted. I thought that interrupting could help, but just continue.
Shall I continue now?
Yeah, continue from wherever you left. Okay, just continue. I'm so sorry.
No. I'm really sorry as well. Okay. So the red line indicated people who had encephalopathy, and the dotted red line indicated people who did not have encephalopathy. The blue line here indicates people who required hospitalization, and the dotted blue line indicates people who did not require hospitalization. And again, on x-axis, we have number at risk, and on y-axis, we have outcome probability. And you can see that the continuous lines are far steeper, and they are higher above the dotted line. So which it just means that people who had encephalopathy or people who were hospitalized were at a greater risk of developing any particular neurological or psychiatric disease versus people who did not have these, who did not have encephalopathy or who were not hospitalized. And it was same for all the disease, be it dementia, be it anxiety, be it or muscle disease, any like this is a neurological disorder. They were like all same. To quickly sum up what we've discussed so far, first of all, it's really important to identify that this research is really valid because our sample size was of over 200,000 people. There was also like matching done like for 55 variables, so the chances of errors were significantly lesser. And they also did propensity score matching, so the error was minimized as much as it could. The data from this study concluded that the neurological and psychiatric outcomes do follow COVID-19, and people who suffer from COVID-19 are more susceptible to these outcomes as well. It also proved that people who had COVID-19 and then the severity of COVID-19 also influenced the outcome that mental illness would have. So the severer the disease, the worse would be the prognosis, the mental illness that you would have. It was also found out that people who had hospitalization had significantly greater hazard ratios than people who had ITU admission or risk. To also summarize what we've discussed so far, we also found out that the other 4 index events and people who had those index events were like at a lesser risk compared to COVID-19. So the psychiatric and neurological detrimental effects that followed COVID-19 were not just attributable to it being any other illness. They were far greater than any of those index events. We were able to conclude that COVID-19 does not only have detrimental respiratory and systemic effects, but it's also it also causes far greater outcomes that are neurological and psychiatric. We were also found out that in an estimate of 33.62% of the population that received COVID-19 diagnosis also received a psychiatric diagnosis in the 6-month period that followed the diagnosis, which means that out of 100 people that suffer COVID-19, 33 people are going to have a psychiatric or neurological condition, or like to put it in a simpler way, 3 out of 10 people who have COVID are also going to have a neurological and psychiatric disease. And this ratio is not negligible. And as healthcare providers, it's really important for us to keep this in mind when we're encountering patients who suffer from such particular conditions. It was also found out that the severity of COVID-19 infection was associated with increased neurological and psychiatric sequelae that followed COVID-19. There's also like a few shortcomings in this study that I personally felt like could have been improved. So the first one would be like really obvious that the data we collected was from TriNet X, which is an electronic health record, and it could there were shortcomings that were attributable to electronic health records. There was like no confirmation of diagnosis, there was no validation of diagnosis, they were incomplete records, and there was no information available on like the socioeconomic status of the people in our cohort or on the lifestyle that they led. So this and affect a person's mental health. If we don't know about that, these are like a few things that could be altering the result of our study as well. Also, since this was an electronic healthcare data, there was like also no information available on the quality of healthcare that was being provided to the patient. So it could be that a person did not have a severe infection, but due to poor healthcare being provided, they progressed and they developed an infection that's severe. So I feel like this data was missing, and it's really important for like further clarity and understanding this particular case study. Thank you so much for listening to me so patiently. Does anyone have any questions? You can type them in the chat box as well, or just unmute yourself.
I have a question. My name is Khalid, and I was going to ask you about the cause of the psychiatric outcome. I mean, we know that it's COVID, right? But could there have been a confounding factor, like, let's say, everybody was in the lockdown, right? So like the condition of the household and, the people's behavior towards them, etc., or the depression from the news, and a lot of myths were out there about COVID and fear. Could that have been a confounding factor, and that led to the psychiatric disorder a lot more than we could have expected?
Sorry to interrupt. Assalamu alaikum. I'm Ehsan here. Before you go to Q&A, I would like to correct 2 things. One thing was about the hazard rate and ratio. So throughout the paper, it's actually the ratio, not the rates. Navaira was mentioning about the rates. It's actually the ratio. Ratio and rates are 2 different distinct things when we are explaining the statistics. Ratio is with a relative term, whereas rate is out of 100. So it's one thing that I wanted to correct. The second thing Navaira said about was propensity score was done to reduce or maybe like remove the errors. It's actually to reduce the noise in the database. So when you have big databases like this electronic health record, there are thousands and hundreds and thousands of cases. When you are doing this kind of a work, you need to match the patients of similar cohorts so that you can reduce the noise. It's in fact reducing the confounding factors. And that's the main thing. So I wanted to just correct these 2 things. Otherwise, Navaira, it was a good presentation. Thank you.
Thank you so much, Dr. Ehsan.
Navaira, thank you so much for the presentation. It was a very well presented presentation, and also the slides were pretty exciting. Now, before the Q&A, I would like to invite our discussants to come up and present their views on it, and probably the cohort can also ask their questions from the discussants. So I would like to invite Dr. Aadil to come up and discuss his points first. Thank you so much, Dr. Aadil.
No, thank you. First of all, to Navaira, really good presentation. And I would say it was a really big article to dissect, and you did a really good job in highlighting all the important points and, you know, raising all the limitations as well. So thank you for the presentation, and thank you to the organizers for inviting me here. I would like to begin the discussion from the last question, you know, and I think one of the students asked, what is the cause of these increased neuropsychiatric problems? And I think Navaira also highlighted that it's a retrospective cohort study. And one of the limitation of these studies is that it's almost not possible to find a causality. These sort of studies are basically used to find associations. And that means that if two things are happening together, doesn't necessarily mean that one thing is the cause of the other. And in order to find causality, you have to do like long-term prospective trials. But finding associations is also very important, and it can give us really good insight about what sort of confounding factors there are, or what sort of risk factors there are that may be playing a role in the cause of a disease. So we know from this article that mood disorders and other neuropsychiatric disorders almost doubles in some instances in patients who have COVID-19 and those who are hospitalized with COVID-19. And there are a lot of various theories going around right now. One of the most common one that is being theorized is that patients who have COVID-19, they have an increased inflammatory response or higher inflammatory markers in their body. And that inflammatory reaction may be playing a role in activating mood disorders and psychotic episodes. We know that patients who have depression and other psychotic disorders, they have increased level of interleukin, cytokines, TNF, and that play a huge role in activation of those disorders. So this is one of the theories. The other factor that can be playing a role is that patients who are hospitalized, they are also given medications that corticosteroids, medications that can play a role in activation of certain disorders. We know that steroids, for example, are famously linked to activation of mania and activation of depression. So that's the other probable factor that is playing a role. And besides that, there are so many other factors in play. Like when someone is admitted in a hospital, they are kind of cut off from their family. They don't have any sort of social support or any community support, and those factors play a role as well in progressing of any psychiatric disease as well. So that's one thing I just wanted to highlight, that there's a difference between association and causality, and that should be kept in mind while we are looking at a paper. The other limitation that was also highlighted was that all of the records are basically derived from an EMR, meaning like an electronic health record. And we are kind of dependent on what the doctors are documenting. And many times, a lot of disorders are not documented. And the authors especially put an effort highlighting that delirium is very prevalent, and especially in patients with COVID-19 who are hospitalized. But they thought that it's not diagnosed at the rates it's been diagnosed in other hospitalization. And if a patient has like hypoactive delirium, for example, like it's not severe, causing a lot of behavioral problems, it's less likely doctors are going to document that because they're not going to be treating it. So we also have to keep in mind that these hazard ratio, no doubt, very, very high. I still feel they're like underreported. And the pandemic has caused this mental health crisis, which is way more worse than we already know. I'm currently working in a child psychiatry unit right now, and I see at least 10 to 15 patients every day who are there for suicidal ideations or after suicidal attempts. And these numbers were like 1 or 2 before the pandemic. So there's this huge COVID-19 pandemic going on. And then there's this huge public mental health crisis going on. And it looks like that there is some focus on treating the COVID-19, but unfortunately, there's not a lot of efforts that are being made to help patients with the mental health illness right now. I just wanted to highlight these two limitations, and I think it's a really good paper overall that signifies the importance of mental health care need in the hospitals and in patients with COVID-19. What can be the remedy or what can be the solution of all of this? In our hospital, what we did was that we made a rule that any person who reports any sort of mild depression or anxiety, we are going to be very liberally be consulting psych team. And we were very liberally using SSRIs and other antidepressants. And there is this new study that was recently published in JAMA that found that patients who were prescribed SSRIs, they had a lower mortality risk, even if they get diagnosed with the COVID-19. And there's another SSRI, fluvoxamine, which is like one of the SSRIs with the highest half-life. They found that it decreases the inflammation secondary to COVID-19, and it even reduces the risk of hospitalization in patients with COVID-19. So there's all these interesting trials going on, and I think that the solution is to consult as much possible the mental health care providers and use psychiatric medication, educate the patients about psychiatric medication, and only then we will be able to provide as much support as we can. For the medical students, I would say that it doesn't matter which rotation you're on, just make sure to focus on the mental health needs of the patient and try to just ask the question, how are you feeling? How is your day going? Are you feeling stressed? Are you feeling anxious? Just asking those basic questions can go a long way and help our patients a lot. So I think I'm gonna stop here and give the mic back to Dr. Nimra. And if anyone have any questions, I will be happy to answer.
Thank you so much, Dr. Aadil. Do we have any questions from Dr. Aadil? If you do, you can keep posting the questions in the chat box, and we or Dr. Aadil can answer those questions in the chat box. Now I am going to invite Dr. Syed Awais. Welcome, sir. Please take the mic.
Thank you. Thank you. I would like to thank CHSR for inviting me and providing me with the opportunity on talking on the topic. And the medical student Navaira has made a very good presentation. I would also like to thank Dr. Aadil for his detailed discussion. I enjoyed his points. So basically, I wanted to say that just like medical diseases, psychiatric diseases also have their risk factors. We talk about that a person who has a sedentary lifestyle, is obese, and eats unhealthy is more likely to get diabetes. Similarly, a person who has a lot of stress in his or her life, has inability to cope with the stress, and has an inactive lifestyle, is more likely to get psychiatric diseases. Firstly, during the COVID-19 pandemic, people were consuming a lot of news about the disease. Sources of these news were our friends, our families, social media, and media. The news kept changing. At times it was horrifying. At times the videos we watched were terrifying. And at times the news kept changing. changing, and we consume the news not, at least initially, not caring about how reliable or unreliable it is. For example, I had a patient who wouldn't open the window of her home, afraid that the coronavirus would enter her home through the window. So we were having a lot of misconceptions about COVID-19. I had the privilege of working in telepsych with the Mind organization during the pandemic, and we used to counsel the patients and our clients that they should only use reliable information, and maybe they could turn down a bit of this information. Too much information was harming them. It was causing them more harm than good. Secondly, lockdown in COVID-19 pandemic had caused a lot of businesses to close. So we are talking about many people becoming unemployed. We're talking about many people working from home. So a lot of our lifestyles were affected. There were a lot of people who were unemployed who were contacting us at Mind Organization, and it was so much so that at our page we had made an icon for all those who were unemployed or needed some employment to facilitate or catalyze anyone who really had an opportunity of contributing. Furthermore, we were counseling them that nothing really lasts. Economy has been bad a few times in history, and things change, things evolve for the better, and new employment opportunities come. Thirdly, there was a lot of change during COVID-19 pandemics. Schools were being closed. Many people were working at home. Many people had lost their jobs. Many social gatherings were not taking place, or even the ones that were taking place at a very short scale. I had a relative who was getting married, and she only had a few of her relatives on her wedding day. So all of this change and all the uncertainty which the change brought was difficult to digest. There was, for those who have done gardening would understand that when you move a tree from one location to another, it takes some time to adjust to the climate, the soil, and etc. Uh, Humans are also that way. We need some time to adjust to the changes in our environment. To sum up, uncertainty, drastic changes in socioeconomic lifestyles, and fear of the disease had caused significant stress. This stress acted like a catalyst to cause diseases in psychiatry. Some people are also concerned about the possible correlation of diseases in psychiatry with COVID-19 later on, because we're not done with COVID-19. Recently, a colleague of mine got diagnosed, and a family member also, family friend, I would say. So we are still having these cases, and would we have a correlation with psychiatric diseases? So I would expect that the psychiatric symptoms would be fewer and milder, since a lot has changed from the way COVID used to be. In the first place, a large percentage of the population has been diagnosed with COVID-19 and recovered from it. We are not as scared as we were from the disease in 2020. In 2020, we wouldn't leave our homes. We were homebound. We weren't meeting our friends. There was all this news on media and social media. It, it was all harming us mentally. So I would expect that a year, as the time is going on, people would be concerned about the disease, and there would be an element of fear and apprehension, but it would be nothing compared to what it was like in 2020. I had the privilege of working in telemedicine at King Edward Medical University during the COVID-19 pandemic, and I can clearly remember that there were so many patients who would call and they were so anxious that they had a bit of cough or a bit of sneezing, and they were really terrified. Now those mild symptoms are something we just brush aside. We do not think about it much. We do not fear them much. In the second place, currently patients are having fewer days in quarantine. Fewer days in quarantine mean that in 2020, maybe someone who was diagnosed with COVID-19 would have 2 weeks in at home or in the hospital until the symptoms improve or so forth. Now, what my colleagues are going through a smaller quarantine. It's kind of like 5 days or 7 days. So the impact on the lifestyle, we are not as isolated as we used to be. We are not as disturbed as we used to be in the pandemic. A cousin of mine was diagnosed with COVID-19 in 2020, and he was amongst the earliest ones in our family. And even though he had milder symptoms and he wasn't much, he was coping with the disease. A real problem that he had was that uh, he was uh, uh, he was worried how he would be spending all these days alone in his basement. In the third place, people were spending most of their times at home. Children weren't going to school. Many people were working from home. Some people were unemployed. Social gatherings weren't taking place. We weren't meeting people. Most of our interactions was online, and it also was limited. So there is a hadith which goes like, we need each other. We need human beings as a therapy. So we weren't having that in the COVID-19 pandemic. To sum up, the amount of fear and isolation is decreasing with time, and hence you would expect milder and fewer symptoms of the psychiatric diseases as the time goes on. So I think I have taken some time. I'll let the remaining time go to the question and answers.
Thank you so much, Dr. Ahad, for your expert opinion on it. And we really hope that as soon as the pandemic settles down and we are back to the world, we will see less cases and hopefully milder cases if the cases do arise at all. Please, every one of you is welcome to ask the questions. We have our worthy discussants with us. So please come up with questions.
I have a question. Can I ask?
Yes, you're audible. Go on.
Okay. First of all, good evening to everybody. Secondly, as we just discussed, according to the findings and data shown in this study, it's very clear that the number of COVID patients was markedly increased in those who were hospitalized than those who were not. What I interpret is that usually people go to hospitals at the latest stage of disease. And the other reason could be that the patients, as they're distant from the families and friends, this is the reason of the mental distress. But what I really want to know is there any relation between the medications used during that treatment to the mental distress, like some psychotropic drugs or some other medications? Do they have effect on the mental health of those hospitalized patients?
Yeah, Dr. Ahad, do you want to go first, or? I can try to
I think the question was that so the question was that people were getting medications, and were the psychiatric medications they were getting, were they harming people? So in my opinion, people were getting very few medications, as we were serving on a few fronts. We were serving on telepsych, we were serving in clinics. In telepsych, we would advise minimal medicines, and generally for the psychosis, or when we think thought people would harm themselves or others, we would have referred them to clinics. And the number of patients going to clinics because of the fear of hospitalization, going to the hospitals and stuff, I don't think as many people were going to the clinic. So I think the amount of medicines were less, and I don't particularly know of anyone who was harmed by any psychiatric medicines during the pandemic. So do you want to add to it, Aadil, Dr. Aadil?
Yes, absolutely. So patients who are hospitalized are definitely at a higher risk for psychiatric illness, and the main reason is that they're socially cut off. They don't have family support. They don't have the spiritual or religious support they require in the hospital. On top of that, they're getting antibiotics, antiviral medication, steroids. All of them can be a contributor towards mood disorders and other psychotic disorders. The medications that we have, luckily, are extremely effective for these psychiatric problems. Like, for example, SSRIs they take their time. They take at least 3 to 4 weeks to work, but they are extremely effective for patients with depression. We have mood stabilizers like valproate, lithium, very, very effective for the phases of acute mania and overall mood stabilization. For psychosis, the medications it takes 1 or 2 days to see the response. Second generation antipsychotics are very, very, very useful. So if I'm on a consulting service and I see patients in the COVID wards or in the ICU with any sort of psychiatric symptoms, I provide the patient with the relevant psychoeducation and I start the medications right away. And the second thing I do is I start therapy. It can be basic supportive therapy, or it can be cognitive behavioral therapy, but that requires a lot of time and effort. You have to see the patient more frequently. And the third thing I do is that I contact our chaplain or spiritual services. And if the patient requires spiritual support or religious support, the priest or the imam is there to provide the help. So medication, therapy, spiritual support, if all of them are in place, I see a really good positive response within 1 to 2 weeks.
And I also think another factor might be in play that the people who are particularly hospitalized, they are also afraid of death, because obviously hospitalized patients have a higher death ratio. So obviously they'll be naturally apprehensive about their deaths as well. So that is something that adds to such high rate of medical distress, mental distress as well. Do we have another question?
Yeah, while we wait for the next question, I can just comment on that. You mentioned being afraid of death, and like in our hospital, we have phones available in most of the rooms, but it now became like a 2-step process. First, you have to like sanitize the telephone and then give it to the patient, and it kind of became a barrier because there's not enough nursing staff to take the phone to the patient. And that started to play a role in cutting off the ties of the family and friends with the patient. So that alone made a huge difference. And then we had to intervene, and then we made sure that patients have accessibility of the phone. So social support and speaking to friends and family alone is a huge contributor.
Certainly, definitely. Do we have more questions? You can also type in the chat box.
I have a question, Dr. Aadil, Dr. Ahad. Apart from the pandemic, and maybe something which could also be tied in with pandemic, is the isolation. A lot of people faced isolation with not having other human interactions. If there is another circumstance as an of similar situation we come across where we need to be in isolation or maybe another pandemic, what would you suggest in terms of coping mechanisms, that how should one survive this kind of a situation where they're not having human interactions? A lot of times, many jobs were work from home. They were not having those interactions which usually people have in day-to-day life. What's the best way to cope up if there is a similar thing in future again?
Yes. So if I have to pick up any practice that can help me in isolation, that would be mindfulness-based practices. And of all the various type of therapies that are very effective in the pandemic, mindfulness-based psychotherapies have been the most helpful. Like, they're the most effective, because you basically educate the patient. How can you control your thoughts when you're sitting alone in a room? How can you stop your cravings for alcohol and nicotine when you're sitting alone in a room? So I try to teach basic mindfulness practices to all of my patients. And I try to teach them, even when they're in a hospital, to try to mindfully sit for at least 5 to 10 minutes. There are so many good applications available on iPhone and iPad that can be utilized for that. But once you start doing that, you kind of learn how your mind is playing with the thoughts and how you're able to control them. So it kind of gives you some insight on managing your thoughts.
Will you like to name those resources, Dr. Aadil, the ones you mentioned, the applications?
Oh, the most common one that I recommend is Headspace.
Okay.
And then there's a second one that is called Calm, C-A-L-M. So it plays certain sounds and tones that are very helpful as well if you don't want to meditate.
All right. Thank you so much, sir. So I think we don't have any further questions. I'm really thankful. Just a second. All right. So sorry for that. I think we're done with the questions. I'm really thankful to Navaira and our worthy discussants who came to the session today, gave us their time and expert opinion. We are very thankful to you, and it was a very, I think, helpful activity for all of us. We learned a lot about research in general and the issues related with COVID as well. So thank you so much. I think we have another question. All right, that's not important right now. So now, thank you so much, Dr. Aadil, Dr. Syed Ahad. Now I would like to invite Dr. S to come up and say a few words. Thank you so much.
Hey, yeah, I just wanted to chime in. Thank you very much, Dr. Aadil and Dr. Ahad. Aadil Bhai is our senior, and it's a privilege to have him today here. It's been, it's a long journey of FMHIs who make their journey out, and he had been a great mentor to a lot of other people that, as well, especially the ones who are interested in psych. I've known Aadil Bhai forever. So through my school, college, and from FMH. So I would say to all the medical students here, if you ever want to actually make a career in psych, if you have one role model to actually follow from FMH, he's here. And it's not to exaggerate or anything. It's a fact. I have seen his journey personally. I've known him, and he's the person who from FMH went to Rutgers, and next he's going to Yale. If in US, if you talk about big places, these are these big places. Yale is a brand itself where he is going. So for all of you guys who want to make their career in psych, if you want the right mentor, you don't have to Google, you don't have to write emails to anybody else. He's the person. So I would ask Aadil Bhai to add a little bit, just to tell about what the psych is, just in few brief lines, that how to make a career out of psych and how the academic psych looks like. So just for the understanding of the medical students, sir. Thank you very much.
Thank you so much, Zil-E-Ali. We have been together for a really long time. That is true. And I would say that किसी को भी अगर कोई support चाहिए हो, कोई information चाहिए about psychiatry